So now coming back to the disease complications, how all this can cause complication. In general, the greater the initial serum osmolality, okay, the BUN and the blood glucose concentration, and the lower the serum bicarbonate level, the greater is the mortality, okay. The severe is the DKA, okay. The severe is the diabetes, I mean the sugar, the severe is the ketosis part, the severe is the acidosis part, then the mortality is going to be greater, okay. The infection and myocardial infarction are the main contributors of the mortality. Understand, when you say that the patient is having a severe DKA component and the DKA is intractable, it means that you are missing out something else. There should be some trigger for the DKA to happen, right? If it's going to be intractable, then you are missing out an infection or maybe a myocardial infarction. So this is the reason we always advise you to do a ECG. The ECG is not only to look for hypo or hyperkalemic changes, it will also tell you about the myocardial infarction status, okay. And always check for infection also. Infections are the main trigger of DKA, okay. Diabetic patients are more prone to get infections, okay. Severe volume depletion in elderly, and elderly I mean this patient can be immobilized also, they will be less mobilized people, so they have higher risk of deep venous thrombosis, okay. So altogether, the complications of diabetic ketoacidosis are, so this can be an exam question, dear friends, okay. You need to divide it like related to acute disease, complication related to therapy, complication related to later time, okay. So acute disease, the patient can have loss of airway, the patient can go in for full-blown sepsis, the patient can die of even myocardial infarction, the patient clinical condition can worsen because of hypovolemic shock. These are acute things which you need to follow, okay. Any patient who is coming to your emergency department, your mantra is ABC, right? Airway, breathing and circulation, right? So those are the things here in acute diseases as well. Along with you look for sepsis, okay. Related to therapy, once you start your therapy, you need to understand whatever value, the electrolyte value you have in your hand can be a false elevation or false low values, okay. So you need to keep on monitoring. Among those electrolytes, it is the potassium which is going to kill the patient, okay. The patients are more prone to get a clinical severe hypokalemia. So related to therapy, hypokalemia, hypophosphatemia, usually hypophosphatemia will unmask on day 1 of therapy, 24 hours after initiation of therapy, right. Then is acute respiratory distress syndrome. Whenever you start enthusiastically overloading the patient without clinically proper examination on and off, then you are going to put a patient into acute respiratory distress syndrome. This acute respiratory distress syndrome is not only because of fluid overload. It could be because of poor ejection fraction of your heart. It can be because of leaky capillaries of your lung, basically maybe a pneumonia, we don't know. And the patient can have a renal disease as well. So this all forms a good team, right, in handling the volume status of the body. So if there is any compromise in renal or cardiac, all the pulmonary functions, and without assessing, you're going to load the patient with more amount of fluids, the patient can go in for acute respiratory distress syndrome, okay. Next is cerebral edema. Okay, so we saw how a cerebral edema can kill a patient, right? Whenever there is serum osmolality increases, see this is the brain, okay, consider this to be the brain, okay, when there, and this is the blood vessel. Whenever the serum osmolality increases, okay, water molecules from the brain comes to the intravascular component, so that the brain goes for shrinking. To avoid shrinking, what the brain does is, it creates some osmotic active molecules. It creates some osmotic active molecules, so that some amount of water retention happens in the brain. So brain is prevented from going into hypercontraction, okay. So this is the some reflex changes in the brain. So once you start correcting this vascular hyperosmolality, once you decrease the hyperosmolality, okay, once you decrease the osmolality of the blood vessels, then the water need to go inside, okay. So you have decreased, the osmolality is decreased. Once the osmolality is decreased, the water tends to go inside, understand this. The real reason behind this is, whatever molecules already formed here will take time to slowly resolve. So the brain component will look like as if it is hyperosmolar because of the preformed components, right? Preformed components. So the water from the vessels will jump into the brain, causing massive cerebral edema, coning, coma, and may cause death and respiratory failure as well. Okay, so this is one reason you need to concentrate on the osmolality. It has to be brought down very slowly, otherwise you're going to kill the patient because of cerebral edema, right? And of course hypoglycemia. Whenever you treat a diabetic patient, be careful, the patient going for hypoglycemia as well. So later complication, recurrent anionic gap metabolic acidosis. Understand this basic component. DKA, when you're handling it, you will have the goals of your treatment, right? Once the goals of your treatment is achieved, it is not that it will not recur. Okay, you need to keep on addressing again and again and again. Look for anionic gap acidosis again. Look for a recurrence of decay again in this patient. Okay, so recurrent anionic gap metabolic acidosis is definitely a late complication. So this is one reason when you start giving your insulin infusion, at one point of time when you're planning to stop the insulin infusion, you're going to bridge it with your subcutaneous insulin as well. Okay. And next is non-anionic gap metabolic acidosis. How come a non-anionic gap metabolic acidosis comes in this decay picture? Because of two reasons. Reason number one, the fluid which you are going to use. Okay, when you start using the normal saline and stuff, that itself can produce more amount of chloride load in your body. Because of the high chloride load, hyperchloremic acidosis will present. Hyperchloremic acidosis is written here as non-anionic gap metabolic acidosis. That is number one. And second, the basic physiology of decay itself tells you that when the ketones are lost in the urine, if your patient has a good urine output, when the ketones are lost in the urine, for exchange of ketones, the chloride is being reserved or preserved or absorbed from the glomerular capillaries. So by that reason also, the chloride is going to be very high in the patient's body. So this all puts together, hyperchloremic metabolic acidosis will happen. So you need to keep on concentrating on your VBG to look for this kind of acidosis. And if at all you allow this hyperchloremic acidosis to occur, then ICU admission or recovery time is going to be more prolonged. Okay, hospital stay, ICU stay, and moreover the complications of ICU and hospital stay are going to be prolonged. Okay, vascular thrombosis. Any patient who is having a hyper concentrated vascular fluid, the blood I'm meaning, because the patient is dehydrated, the patient can be in an immobilized state, all these things will put to the patient has vascular thrombosis. This thrombosis can happen everywhere. Okay, it can happen even in the CNS. DKA can lead to a cerebral CVA status as well. Okay, and of course mucormycosis. Not only mucormycosis, any fungal infection is going to be more common when the sugar level increases. Okay,